All right, guys, we're going to move on to pediatric emergencies. So this is all the some of the emergencies you can encounter for the like child population, right? We'll talk all the way from like 0 to almost your age, right? So we will talk about all the different conditions you might see. The big difference here for us is going to be that there's anatomical differences between adults and children, and we need to take those into account when we are doing that. So understand parents can either be allies or a problem. You need to develop that good rapport with both. So just understand that there's multiple people in the room, and you got to talk to everybody. And if the parents feel that they're not being listened to or something, that's just going to be a problem for you. So you do have to kind of play that. You got to do both. All right, you can treat the kid, but you're also effectively going to treat parents. Okay. So some of those differences between adult in a child is that a child's airway is smaller in relation to the rest of the airway, and the tongue is bigger. Okay, so smaller airway, larger tongue. All right. Also, the upper airway is a lot more flexible, and infants don't even really use their tracheas a ton in the first 6 months of life. The trachea is about the diameter of a straw, so it's very, very small. Children use up about twice as much oxygen as an adult. So if there's a respiratory issue, it presents itself real quick because they're in trauma much quicker than they would be as an adult. Okay, so someone put this together. It's the pediatric assessment triangle. This is a little thing to kind of remember some of the priorities when you're assessing a kid. So first one is appearance. We're looking at that heart, lung, central nervous system. Okay, so we're doing overall appearance. Are they talking to you? Are they looking at you? Do they interact with you? They have good muscle tone, skin color, that kind of stuff, and reassess that often. Okay, so this is what we're looking at. So in the middle there, that's the things that we should see, if we see any of the stuff on the right, we're in trouble. So the other part of the triangle is work of breathing. So it's going to be just how much difficulty breathing do they have, right? So you can assess that by looking at these things here on the left. All right, do they have abnormal breath sounds? Are they positioned in a weird way? Do they have retractions like between the collarbones, and the skin's really pulling in as they're trying to breathe? Those kind of things. So keep an eye on those. And then last is going to be that skin. So what's the color? Is it mottled? Is it gray? Is it blue? Like what's the skin color look like? So just remember the three components of the PAT. Okay, so respirations, count respirations for 30 and multiply by 2. That's just a better way to do it because your margin of error is a lot smaller, okay? And then we kind of already mentioned, but keep an eye out for those abnormal things such as snoring or grunting or wheezing, and retractions, all that stuff. So you're assessing for any sort of respiratory difficulty. Okay, check a pulse rate. If it's child younger than 1 year, brachial pulse, just in that picture, okay? So yes, we do have to kind of know these, okay? I will ask you this on the test, and that's simply because if you have a newborn, if you're a 2-week-old child, you need to know, oh, it's 80 beats a minute. That's good, right? Well, yeah, for an adult, but not for him, right? So we got to know these numbers. Okay, we'll talk about this a little bit more later, but high body temperature, it can be, fever. Kids get illnesses various times. If a fever is bad enough, it can develop a seizure. So normally, if there's a cardiopulmonary arrest, as in the heart is stopped, usually it has nothing to do with the heart. Especially for children, it's usually some sort of airway issue has gotten worse and worse and worse and worse and worse, and now the heart is stopped. And you can also have things like croup and epiglottitis, and we'll talk about those a little bit later. Okay, so head, tilt, chin lift, you remember that. Do not hyperextend the neck when you tilt back. You might even want to put a towel or thing on the shoulders. But now CPR, if you are alone, you need to do 5 cycles of CPR and then call EMS system. And the reason why is what they're worried about is that you're going to be on the phone, doing the 911 thing, tell them where your address is and tell them what's going on. And the whole time, this kid is just, they're not breathing, right? So they want to do 5 cycles first to kind of get a little bit going and then call EMS. And that's because children are so much more sensitive than adults, okay? But same idea of CPR. Yep, same idea. Okay, suctioning, gotta have suction. There's a good chance vomiting will occur at some point, so make sure you have that ready. So airway obstructions, kids like to eat things sometimes, right? So The rule is if it's a small obstruction, try to let them cough it up, give them some oxygen. It's okay. Also, and speaking of if you need to get some oxygen, some children, especially if they're freaked out, don't want a mask on their face, right? So you can even just hold the mask like an inch away from their face. That helps. Okay. Now, with a severe airway obstruction, we actually need to get in there with the Heimlich maneuver. Okay. So mild airway obstruction, they can still kind of pass air. You let them cough it up. Severe airway obstruction, you're in charge. Okay, same for adults, Heimlich or abdominal thrust as it's called now. Just, yeah, get it out there. So assess, the good thing about babies is they cry. What I say is a crying baby is a good baby, because if my baby's crying, whew, at least I know his airway's good and that he's awake and he's paying attention. Okay, there's nothing worse than like a limp child. That's the worst thing you could run into. So this is from CPR stuff, and I know some of you didn't get to go to CPR because of what happened, but that you do a mixture of, you can actually do some chest thrust and abdominal thrust and back blows to try to get that stuff out of there. So combination, back slaps, and then the kind of chest thrust, and that's going to hopefully pop whatever that is out of the way. Okay, respiratory distress, a breathing rate of more than 60 that's pretty fast for infants, or a breathing rate of more than 30 to 40 for children. So there's a slight difference there. But either way, that's not good. That means the body's trying to catch up with something. You might see them cyanotic with the kind of blue and gross. Altered mental status, they might be kind of combative. Try and determine that cause, because remember, these guys can go down pretty quick if it's a respiratory issue. Usually the child is sitting up, but really, however the patient wants to sit, if he can breathe, it is good. Keep the patient calm, administer oxygen, take to the hospital. So on the respiratory, that was like respiratory distress. This is now respiratory failure, okay? A breathing rate of fewer than 20 in an infant or fewer than 10 in a child, boom, that's respiratory failure, and now you're real worried now. And they will be unresponsive. They maybe even have a decreased or absent heart rate, and they will maybe not have they will not have pulses either. So if you're in this zone, the respiratory failure area, it's really scary. You got to go to the hospital right away. So do CPR if you have to, mouth to mask ventilations, use the oxygen tanks, whatever you got. And if their heart rate is less than 60, you got to start CPR. And remember, the most common cause of circulatory failure in children is respiratory failure, okay? So it usually means there's nothing wrong with the heart, it's something else is wrong, and that eventually leads to that. If the heart rate is more than 60, complete your normal assessment, support ventilations, get your vital signs. If less than 60, then you got to basically CPR. So there's a few causes of altered mental status in children: low blood sugar, poisoning, post-seizure states, infection, head trauma, decreased oxygen levels. Okay, so those are just some of the things to keep in mind if a child is having some sort of illness. So asthma, we've already talked about this in class. It's kind of that, some people call it reactive airway disease. It's the lungs get triggered by something and they start to get inflamed and they can produce some mucus, and then the child start wheezing. So this is pursed lip breathing. What it does is it helps keep a little bit of the air pressure in the lung space and kind of keeps those airways open. So if you see pursed lip breathing, it's actually like a physics thing that the body is trying to keep their alveoli open. All right, croup. I will tell you the things you got to remember about croup and epiglottitis. It's a very common thing. These are common, so we got to really tease out the differences. Croup is upper airway and occurs between 6 months and 6 years. And it has a seal-like barking cough, or they call it a seal bark cough or something. I can send you a video of it. So it's basically just a very noticeable, weird cough, okay? And that's going to be the main sign and symptom of that, okay? It's for our purposes, for remembering. 6 months to 6 years, and it has seal bark cough. They really, they don't like to lie down, and they're usually not that afraid. It's just kind of a cough. Moist air, like bathroom door, hot water, shower kind of thing, has been shown to relax some of the vocal cords and ease some of that pain. Now, epiglottitis is a severe inflammation of the epiglottis. Sometimes it's so inflamed that air barely moves. And it usually occurs between children ages 3 to 6 years, okay? So 6 months to 6 years, 3 to 6 years. And the classic sign of epiglottitis is drooling, all right? So They might actually present initially, like over the phone, they'll present the same. You can't really tease them out. But the big thing there is does he have a weird barking cough, or is he drooling? And that's one way you can kind of guide your treatment. So with epiglottitis, we don't want to handle them a lot. We certainly don't want to put anything in the mouth. The epiglottitis makes everything so inflamed that it can actually spasm and close off. So this is definitely emergency. Go to the hospital. Big deal. Drowning, second most common cause of accidental death in children. So it is something you're going to run into. Just make sure you're not putting yourself in danger as you attempt the rescue. All right. Yeah, of course, if there's no breathing and no pulse, got to do CPR. If you pull them out, there's some water, get that water out. But I will tell you this, that if a kid is coughing up like foamy, gross saliva stuff, that's a bad news, and he might actually end up dying. So, and the reason why is what that means is that there's water that got down into the lungs. Water's not supposed to be there, and it washes away the surfactant in your lungs, and the surfactant helps keep the alveoli open. So if he's coughing up stuff, that means he's got water in his lungs, and those mean the lungs are going to start to fail basically because they needed that surfactant to keep the alveoli open. And if you wash it away, then the lung might actually start down. So oxygen, and then quick evac to the hospital. Fevers, we talked about this a little bit. They're common in children. The temperature regulating mechanism in children is just not really fully developed, so they can spike a pretty high fever pretty quick. At this point, if once you're 104, you need to get that heat out. Some people say, oh, let him have a fever for a little bit. Maybe to help kill the thing, maybe. But at 104, no way. You got to uncover the child. You got to fan him, cool him down. You got to do all that stuff. And then keep an eye out for seizures because it may have gotten so high that the child actually sees. So now a kid might not have a seizure in the way we would recognize. Okay, they might eyes roll back, teeth become clenched, lip smacking. It might be something as small as that, or it could be full body jerks. Okay, look at that skin color during the seizure. That means they're probably not breathing that well if it starts to turn different colors. Okay, but provide oxygen, prompt transport, ABCs, and once again, cool that patient down if they have that really high fever. Vomiting, diarrhea is super common for especially the younger children. They can get dehydrated very, very, very quickly. So if you got called to a young child, altered mental status or something, one of the first things you can ask is, well, how many wet diapers has he had today? And let's just say it's 5. Okay, well, is 5 normal? Is it less, more, whatever? And that's a good way to figure out if they're dehydrated. Abdominal pain, appendicitis. I actually had a student this year who had that happen, so it does happen. The child's going to be pretty nauseated, lots of pain. They could even be vomiting, and we're going to want to evacuate that patient for sure. But any sort of abdominal pain, we don't have X-ray vision. We can't really see what's going on in there, so I would take them in. So poisoning, yep, it happens. Once again, children like to eat a lot of stuff, so you can look for chemical burns and stains around the mouth, nausea, vomiting, abdominal pain, diarrhea. All that stuff can be if they ingested something bad. Worst case scenario, you're going to have breathing issues, unconsciousness, seizures. Try to identify the poison if you can. Scene safety, of course. And if there's just the random pills lying around, grab them, and you can take them to the hospital with you. In the meantime, if for whatever reason you have time to do it, there's pill identifiers on the internet, so you can type in the shape of the pill, the size of the pill, the color, and it'll tell you what the medication is. Contact the local poison control center if you need to. Everyone should have that number in their phone. Those guys are the experts for this stuff. You may need to do activated charcoal. If you remember that, we've worked during the poisoning lecture. It has stuff that kind of binds to the poison so the child does not absorb it. Okay, so they can do it. These are just a few different ways that a child might be exposed to this. Just remember, if it's a dry chemical or something, we want to brush the chemical off, and then we want to irrigate water. Okay, but always keep an eye on the respiratory and mental status situation. So, sudden infant death syndrome is a sudden unexpected death of an apparently healthy infant, as in there was no other pre-existing conditions. It usually occurs between ages of 3 weeks and 7 months, and oddly enough, there is no adequate scientific explanation. They're still working on it. One thing that's been shown to help is sleeping on the back. So there's a statement that says, put your baby back to sleep. And that apparently has made a difference. If the infant is still warm, begin CPR. However, remember those signs of obvious death, right? If you got that really bad dependent lividity, that cannot happen with an alive patient, okay? So if you get called to a potential SIDS thing, you want to keep an eye out for those signs of death when you start doing CPR. Pediatric trauma, #1 killer of children. Basically, remember, blood loss is blood loss, right? Broken leg's broken leg. But understand that a child cannot communicate symptoms as well as an adult. They may be shy, they may be more easily overwhelmed, a lot more anxious, those kind of things. Different size materials potentially. And remember that compensation thing. A child does not show signs of shock as early, but they fall off a cliff when they're ready. So their body compensates, falls off a cliff, done. Whereas an adult, it's like a slow decline. So basically, the patterns of injury sustained by children can be these three things, right? Type of trauma, type of activity, and then the child's anatomy, of course. Unrestrained patients have a lot issues with like head and neck pain, neck injuries, whiplash, that kind of thing. Okay, bicycle accidents that happen as well, that's similar to an adult. Okay, and these are just some ideas of some different kind of injury patterns that you might see in a child. So regardless of any of that stuff, remember, ABC, stop the bleeding, treat the patient for shock, do a full body assessment, stabilize injuries, evacuate, right? So once again, as a reminder, children compensate a lot longer and then crash and burn, okay? So if you are seeing these signs of symptoms, that patient is circling the drain, okay? If you see these signs of symptoms in a child, they are circling the drain. That's cool, clammy skin, rapid weak pulse, rapid or shallow respirations, low blood pressure, all that kind of stuff. If that's happening, you gotta get on it right now because that patient is in a lot of trouble. And just remember, airway obstruction also an issue for these. All right, so car seats. Normally at the hospital, when they take their kid home from the hospital, they actually have to get like instructed from hospital staff on how to put in the child seats because they do have to be done correctly. Okay. Now, if you need to do it in like your ambulance, you can actually rig the car seat to the litter. All right, child abuse. If you are interacting with any children and they seem withdrawn, fearful, hostile, unwilling to discuss certain things, maybe now you're thinking child abuse. Some of those signs and symptoms that you might run into are multiple fractures, bruises, and various stages of healing is a big one. That means damage has been occurring over a few weeks. Human bites, definitely, burns, and then bizarre accidents, just stuff that really doesn't make a whole lot of sense. Children might try and lie about something, right? Because they don't want to get their dad in trouble or whatever the context is. Well, they may not fully grasp like the reality of certain things, so they might try and say, "Oh yeah, I climbed this tree and I fell off," which like makes sense, right? Like you would get injured from falling off a tree, but there's no way that kid could have actually climbed the tree. That kind of thing. So look for reports of weird accidents or stuff that doesn't make sense. Transport the child. They're injured. You got to go. If for whatever reason the parents say no, and I understand that is their right as parents. If it is something bad enough, like especially if it's this malnourished child, unsafe living environment, drugs lying around, unsafe stuff, I would just call law enforcement and have them help you through that. And the last thing is, unfortunately, women or children do get sexually assaulted, and they also might have some injuries at the same time. So try to get as much information from the child and any witnesses, and they need to go to an appropriate facility. And just remember, we don't want to let them shower or do anything like that because there may be some evidence in there. So keep them safe and don't let them do anything as far as taking clothes off or anything, and take them to the hospital and they will handle it there. If you need to, you can talk to a counselor. These are difficult calls. I've only been on a few, but they are definitely difficult calls. So if you have responded to one of these pediatric emergencies and you're feeling like you have issues with it, that is totally normal. Okay, so that was your quick down and dirty lecture on pediatric trauma.